Hi, everyone. Welcome to the online Causal Inference seminar. Today, we have a talk by Mireille Schnitzer from University of Montreal on estimands and estimation of COVID-19 vaccine effectiveness under the test negative design, connections to causal inference. So during the talk, the Q&A will be handled by Dennis Talbot from University of Laval. And after Mireille's talk, we will have a discussion by David Benkeser from Emory University. So I hope you all enjoyed the talk and feel free to ask your questions in the Q&A. The Q&A will be handled by Georgia today, so I'll switch over to her so she can introduce you to that concept.
All right, thank you, Emma. Yes, okay, so as always, please use the Q&A to ask your questions. It makes it much easier for us to answer and keep track of what's going on. So please refrain from using the chat. If your question is asked, perhaps a question that we would like to ask directly, we might ask you to raise your hand and then we can unmute you and ask it yourself. If that happens, remember that you will be recorded. Other than that, Dennis will be handling Q&A. And so now Mireille can take over, and we look forward to your talk.
Yeah, Mireille, whenever you want. Okay.
I'm just waiting for it to go full screen on my computer. Oh boy. All right, it looks good. Awesome. All right, so thanks so much for the invitation. I'm happy to be here today to talk about some work I've done recently in the context of estimating COVID-19 vaccine effectiveness. So I'm going to talk about some stuff that we all know or well been living through. So the pandemic was declared on March 11, 2020, and globally governments started imposing sanitary measures and recommendations. Vaccination was another intervention that became available in some countries in December 2020. And there were a lot of scientific questions regarding effectiveness of different policy and personal measures, and eventually vaccine effectiveness. And basically, answers are needed on a very short time frame for a lot of these questions, even if they're going to be answered imperfectly. And so all of this sort of changed the scientific landscape, the epidemiological landscape. Well, I'm just talking about epidemiology, not the basic sciences that are also evaluating some of these things. And so like new study design started becoming very important. Another aspect is a lot of data started being collected differently. And in fact, different like communities had access all of a sudden to testing for like easy access to testing for SARS-CoV-2 infection, which is the virus that causes COVID-19 disease. And so bulk processing of PCR tests made mass testing possible. A lot of countries collected all of this data. And so a lot of information on positive and negative tests of people going in to see if they had COVID-19 became available to researchers. But in fact, all of this PCR testing stopped recently in Quebec, Canada, at least for the general community. And so now we're seeing antigen tests and optional reporting taking its place. But prior to that point, we basically had all the test results for people seeking PCR tests, and it was freely available for us as it was in many health jurisdictions. So testing is largely driven by symptomatic status, contact tracing, high-risk assessment, or administrative reasons. Some countries made testing mandatory under certain conditions as well. But in particular, it's not necessarily the case that you have to be symptomatic to receive a test, or at least that's not true everywhere and at all time periods. So vaccines became available to at least many rich countries in December 2020. And so here I have a table giving the authorization dates for the FDA, European Medicines Agency, and Health Canada, just to make a few comparisons. So clinical trials before authorization demonstrated efficacy under controlled settings in each age group. In particular, this was under a specific protocol, and then also only collected outcomes up to a certain point. But in practice, jurisdictions varied dosing schedules. So they varied recommendations, or even they mandated differences, like a different delay in between first and second doses. For example, in Canada, this was really, really much longer than and in the UK too, than what was done in the trials. And so here again, we had questions about, real world effectiveness under different protocols. We also mixed vaccine types. So if the vaccines were investigated separately by type, it was sometimes unclear about what the effectiveness would be if they were mixed, like for first and second dose. And so there is and there continues to be demand for observational analyses to establish effectiveness in the real world, which includes heterogeneous populations, heterogeneous usage, and also longer terms. So right now we're looking at how long are the booster doses effective for the current variant. So as variant waves change, we're consistently interested in effectiveness. And so this is why the test negative design became of interest. So we have a lot of test data in populations without doing any extra intervention. And so people were interested in using this design for vaccine effectiveness, but in fact, it's an existing design that's been used to evaluate a vaccine effectiveness against influenza. That's existed or it's been used in practice for a little bit of time now. So this is an observational study design that compares outcomes in people who had symptoms characteristics of an infectious disease of interest and obtained a test. So this was first proposed in 2007 by a Canadian researcher, Skowronski et al. This was used for influenza, and it was increasingly formalized. So what exactly are we estimating using this design was more and more formalized by various researchers. And in fact, causality was also addressed. In the third bullet, I have a few papers that used directed acyclic graphs to identify sources of bias and discuss causality. But as far as I understood, causality was never formally addressed. Like identifiability, for example, of causal parameter was never formally addressed under this design. And so that's kind of one of the things I was doing in this work. And so describe what exactly is the test negative design in the context of COVID-19. So I find that's helpful. So our source population consists of people with disease symptoms, potentially caused by a SARS-CoV-2 infection. So people who think they might have COVID-19 in some sense. So it could be defined as at least one of the symptoms in a list. So it could be like at least cough, or at least fever, or at least something that seems like a cold. And they must have either received, so these are two versions of the design. One version is that they must have received a PCR or antigen test administered at a test site. And another version of the design is that they were hospitalized for illness resembling COVID-19 and then received a PCR antigen test to see what kind of disease it was. Was it COVID or was it something else? So these are two different ways of applying it. There are other ways too, but these are a bit on the extremes. And what we do, so we have all these people who are about to be tested. We effectively or actively recruit from this population prior to the test. And prior to the test, we assume, so the basic premise is that we assume that the individuals did not know their test status, which makes them not distinguished by the nature of their infection at recruitment. That's really important for this design to make sense. These are all people coming in with symptoms. They don't know what they have by assumption, not necessarily in reality. And what we're going to do is we're going to compare their outcomes and vaccine statuses. So what we do is we obtain patient demographic, health information, and their vaccination status. And then finally, we have a test result that lets us know if they have COVID-19 or some other disease. So the test result is whether they have SARS-CoV-2 infection, which could be yes, no. The analysis typically involves a logistic regression, or basically almost always involves a logistic regression of the test result, which is binary, on vaccination status and measured covariates. Vaccination status could be, is typically categorical. So it could be you received 1 dose, you received 2 doses plus 14 days, or whatever categorization they're using, 2 doses plus a booster, 2 doses plus 2 boosters, with some period of time between that and the test. So it's typically categorical. And then vaccine effectiveness is defined as 1 minus the exponential of beta, where beta is the coefficient of vaccination status. So the exponential of beta is like the odds ratio estimand in this setting. So things have been changing because of the pandemic, and the data collection is really different, and people's behaviors are really different. And so it's interesting to look at this design in the current context in particular. So there are different patterns of how and why people are tested. I think with influenza, people weren't normally going to get a test for influenza because they had a contact with influenza. People were typically driven by symptoms. So now it's changed. There's a lot of reasons why people get tested. They might have been coming back from travel and they sought a PCR test. There's also broader availability or in some time periods and some jurisdictions, there's broader available testing for the general community. And there's also broad testing of everyone entering care facilities, or at least often there is. So going to the hospital for a different procedure, you might get a test, you might find out that you do have SARS-CoV-2 infection, even if you're asymptomatic. So these are things to take into consideration to understand what the data mean. Also, we see now in practice that studies are largely leveraging administrative or electronic health data rather than performing primary data collection. This also really responds to the need for a quick response, a quick scientific evaluation of vaccine effectiveness. But we see, I think the majority of studies now are purely using administrative data, which comes with additional challenges, but also with really, really large sample sizes and sort of precise statistical estimates. So in this context, the test negative design allows for rapid collection of data and analysis. Of course, we'll also talk about the reliability of the estimates and the interpretation of them in particular. So this goes a little bit off track from the main goal of my presentation, but I wanted to mention this. Study design is important, of course. And there's an interesting case study from Ontario, Canada, where researchers put a preprint, they put it online on medRxiv, of the results of the analysis of vaccine effectiveness in their province, because in Canada, data is typically available separately by province. There are laws governing access to data. So they used electronic health data, and this study applied a version of the test negative design that included all tested individuals. So they took all their test data and they ran a logistic regression comparing test positives and test negatives versus their vaccine status, adjusted for confounders. But this isn't exactly a test negative design because this included tests of people who did not have symptoms, okay? So the results were that they estimated harmful point estimates of 2-dose and null point estimates of 3-dose vaccine effectiveness against infection by the Omicron variant. So this is the time of this is really recently, the big Omicron wave in like December, January. So these results were discussed online. A lot of people interpreted them as, real estimates of vaccine effectiveness against infection. But the study was reworked to include only individuals reporting symptoms. And in fact, the results changed a lot. So then the results the study concluded that 2 and 3 doses were indeed protective against symptomatic Omicron infection. And so that corresponds more with what other studies are estimating around the world. So it made more sense. The other thing to note was that the original version of the study was stating that they were estimating effectiveness versus effectiveness against infection, whereas the proper application of the test negative design estimates protectiveness against symptomatic infection. And so we'll talk a little bit more about that. That'll be formalized. But that's something important to note, that there's a bit of a question in practice about what's the outcome in these studies. Is it infection? Is it symptomatic infection or something else? So the questions that I address in this study it's almost like it's like an oversimplification of the real world. This is one of the first studies I've done in this area. So we're going to be talking about the ideal implementation of the test negative design and just the interpretation of the estimands and how we can another way to estimate them. So some questions I'll address are: how can one interpret the odds ratio contrasts between test positives and test negatives? Under what assumptions can we connect this estimand to a causal parameter? Oh, sorry, I skipped one. So under what assumptions can we connect? First, can we connect the estimand that we have to a standard measure of association, so not even causal, between vaccination and symptomatic disease or hospitalization due to disease outcome. And then finally, how can we connect that to a causal parameter, and also what are some of the challenges in connecting that to a causal parameter in this context? So to formalize this a bit more, here's the observed data. V represents a categorical variable that is a status of vaccination against COVID-19. So it could be unvaccinated, fully vaccinated. I should have said 2 doses plus X days. This was written, before, when that actually had a meaning. I represents infection. So there are 3 possibilities. So the premise of this design is that there are 3 possibilities of infection. You're either infected by SARS-CoV-2, or you have another infection that could potentially cause COVID-19 like symptoms, or you do not have an infection, or you have maybe you have some other infection that will cause those symptoms. So we'll call that the infection-free state. Okay, so there's 3 categories here for I. W is going to be binary, and it means presence of symptoms. Okay, now by assumption or by definition, actually, the symptoms may only develop if I is not 0. Okay, so by definition, you have some other infection or you have SARS-CoV-2 infection. Then in the version of the design that looks at hospitalized people, H represents hospitalization for symptoms. Okay, specifically for symptoms. So some people go to the hospital for something else, like they broke their leg, they go to the hospital. Oh, it turns out you have SARS-CoV-2 infection. So that doesn't count. You have to be hospitalized specifically for your symptoms. And if that is the case, then you're eligible for inclusion in the study. Then we have covariates measured and unmeasured. C is common causes of, U is common cause of any of the aforementioned variables that are unmeasured, and C are common causes of the outcomes. So it's assumed to not affect V. We only need that sort of restriction for a causal interpretation later, but that's how I drew the DAG. So basically, you can have variables causing any of these other 4 variables. So confounders might include things like age, comorbidities, employment sector. It can include tricky things like perspective on the pandemic, political affiliation, those kinds of things. So very hard to unconfound this kind of design, it seems to me. The variable U is a variable that, so by assumption, only affects the outcomes. Okay, so it's not a confounder. So it could include latent COVID-19 susceptibility. Okay, and so we're allowed to have that kind of variable. So this is the DAG. So measured C can affect everything. We can adjust for confounders, and U are not confounders, and so they affect the outcomes. So you have a vaccine status. You may or may not become infected in some time period. You may not have symptoms, and you may not get hospitalized for those symptoms. And so if we apply the study design to the DAG, so it's always tricky to use DAGs when you're talking about sort of like case control type designs, or in this case, not exactly a case control, but it does have a bias sampling design. So I still think it's interesting because we're formalizing the model that generates the data. But once we want to kind of apply the design to the DAG, it's a little bit tricky. The DAG itself won't show us how certain parameters can be identified. But anyway, in this case, I put boxes around hospitalized to say, okay, we're sampling people who have symptoms and we're hospitalized for their symptoms. So we're conditioning on those things. And then another part of the design actually, so the last part of the design actually controls for infection. So people cannot be not infected with something that could lead to symptoms. Okay, so that's the last thing I wrote here in the legend. Conditioning also results in all participants having some kind of infection that can lead to COVID-19 like symptoms. So basically the way I see it is we kind of block this whole path leading towards hospitalization, at which point you're eligible for the study. Now, in the alternative study design, hospitalization could be replaced by testing. So it would mean someone can get infected, have symptoms, and then those symptoms might lead them to get tested, at which point we'd have a box around testing, a box around symptoms, and then we would still be excluding people who had no infection that could lead to symptoms. Okay, and so then we would have different kinds of confounders depending on the kind of design. And so if we write down the complete data from the underlying population, we have the measured covariates, so complete data, but just of the measured covariates, excluding you. We have vaccine status, infection status, symptomatic status, hospitalization. But our observed data that are under the sampling design are only for those who have H equal to 1, W equal to 1, and then don't have I is equal to 0, so they have some kind of infection. And for them, we observe covariates and vaccination status and the test result for infection. And so it's important to note that the relevant outcome that we'll show is a composite outcome, meaning that you have to be, like, to have the outcome, you are hospitalized and you have symptoms and you have SARS-CoV-2 infection. Okay, so we're going to end up estimating vaccine effectiveness against this outcome rather than just infection itself. So in this next part, I'm going to stop after a few slides for questions. We're going to talk about what a logistic regression is estimating. So first I'll say, how do you apply the logistic regression? So here we have cases and controls, the test positives and the test negatives. Cases are those who test positive. I is equal to 2 means that they were hospitalized for COVID-19. Controls are those who test negative. They have I is equal to 1. So no COVID-19, they have some other illness. This is also assuming a perfect test for SARS-CoV-2 infection. So I'm ignoring that issue now. So with NID samples of the data, what we do is we just use logistic regression and we regress I on the covariates and the dummy variables for vaccination status as so. And so we're minimizing this risk. And so if we look over here, to the linear regression formula, we see that we have main terms V. So here I'm just kind of letting V be binary for a second. So we have main terms V, and we could have main term C, or we can have interactions between C here. In order to get an overall estimate of vaccine effectiveness, we can't have interactions between the C and the V. Okay, so that's important. And what we do is we use the regression to get an estimate of beta. And the exponential of beta is what we're going to be interpreting as the odds ratio. Or we'll see if we can interpret that as an odds ratio. So this is pretty similar to a case control setting. It's not the same thing as a case control. Sometimes it's called test negative case control, but it's not the same as a classic case control. But we can look at that literature to kind of see how to simplify these estimands. And to identify them. So I parallel Prentice and Pike here from 1979. So we have covariates, C and V, sampled from basically a bias probability function. And by bias, I mean conditions on the inclusion criteria for the study. It's a bias sampling design. So this is conditional on having the inclusion criteria for the study, meaning that you have some infection, you have symptoms, you're hospitalized for infection. And then we have infection type that is sampled from an induced Bernoulli distribution with a bias probability, again, conditioning on the inclusion criteria, and also on the covariates. Under correct model specification, the logistic regression identifies the odds ratio of infection type with respect to data Z versus a comparator Z naught. So that means, Z means covariates and some vaccination status versus the same covariates, maybe some other vaccination status. Okay, so we're contrasting different vaccination status in this conditional parameter. And so that odds ratio, it's like an odds ratio, is over here. So that exponential of beta is equal to these ratios of probability. So we have infection 2 versus 1 under a certain vaccination status and covariates. And then vaccination 2 versus 1 under different vaccination status and covariates. And all of this is conditional on the inclusion criteria for the study. And then using the definition of conditional probability, we can simplify that odds ratio and we can rewrite it as a sort of a different odds ratio. I called it like quote unquote odds ratio because we're not contrasting an event versus the complement of that event. We have 1 and 2, so 1 does not include I equals to 0. But anyway, we can rewrite the previous equation as this simplified odds ratio. And importantly, this is perspective. So we've gotten rid of the conditioning on the inclusion criteria. So each of these probabilities is what I would call, I don't know, perspective probability. Maybe I'm not using that term properly. But it's the unbiased probability of having COVID-19, so having SARS-CoV-2 with symptoms and hospitalization versus having another illness, symptoms and hospitalization. But even here, is this really interpretable? We're contrasting being hospitalized, the probability of being hospitalized for COVID-19 versus another infection between fully vaccinated, for example, and unvaccinated individuals. That in itself is not that interesting. But I notice that in practice, a lot of people kind of stop here with their interpretation. In application, like when I see test negative design studies, this is how they interpret the parameter, because this is strictly true. This is indeed what you're estimating, but can we go further with this interpretation? And so it's known in the literature that if you make this additional assumption, you can improve the interpretability of that parameter. So this assumption is that the COVID-19 vaccine has no impact on any other type of infection, the ensuing disease activity, or the potential for hospitalization. Once you have this, so intuitively what this means is that your control group that has some other disease is actually representative of the source population. That's what that gives you. So it kind of gives you a case cohort study. And so formally we can write that as the probability of having the control condition, so some other infection and hospitalization and symptoms, is independent of Z, basically, or at least as the way I define it. You can vary the vaccination status and keep the covariates, and then it doesn't change the probability. And under this assumption, the previous odds ratio simplifies to a risk ratio. And so this is highly interpretable, and also very standard. So now we're just we're contrasting the probability of having the outcome of interest, so the COVID-19 with hospitalization, between different statuses of vaccination. And so thumbs up, this is the estimand that we want to interpret, but only possible under this extra assumption. So we need to be mindful of that extra assumption, or else we can't go this far. And then, so through all of this, or even if we don't make this extra assumption, vaccine effectiveness is what they call the estimand, and that's typically given as 1 minus the exponential of beta. Yeah, but specifically, we can see that with this extra assumption, we're estimating the risk ratio for the outcome of interest, which is hospitalization due to COVID-19. So if we talk about vaccine effectiveness, and for this type of study design, we would talk about vaccine effectiveness versus hospitalization for COVID-19 specifically. And so we basically have the typical strengths and limitations of logistic regression. I think the strengths are that everyone knows what it is. There are diagnostic methods available, and it estimates a risk ratio in this context. So under that assumption, it's a risk ratio, so we don't have the problems with non-collapsibility. So its value does not depend on the variables in the conditioning set beyond adjustment for confounding. So these are good things. It can be run on high dimensional data. The limitations are that it must be correctly specified, and in particular, it precludes effect heterogeneity in the estimation of an average association, which means that you either get to estimate the vaccine effectiveness separately for different subgroups, or you can misspecify your logistic regression in the presence of effect heterogeneity. And so you would get biased results of an overall effect in the population. It also, since it's an outcome regression method, it extrapolates into sparse regions of the covariate space, so this can also cause problems. Basically, this is in the context of practical positivity violations. And so one of the problems I pointed out is the effect heterogeneity, and that might be important here because we know that there's low vaccine effectiveness in certain groups, including immunocompromised and transplant patients. So if they're included in your population of interest, of course, we know that you would need to kind of have those covariates and have interactions between the vaccination status, or you could exclude them from your population. But those are just some of the known subgroups. They're known to me, and so there might be others. So that's the first part of the talk, focusing on the typical estimand interpretation. So are there any questions so far?
So we do have a couple of questions. One is already answered, but because they're related, I think that maybe you can kind of address them both. The first one was asking about what is happening with asymptomatic COVID-19 infections. And the second one that I think is related also, there's a question about whether there's an assumption that testing is available to anyone.
It's a really good question. I'll answer that one. That's what
right. So those two, I think that you have. So those two kind of complicate the data that you have. So I think that if you can try to address them.
Yeah. Okay. So is testing available? Do we need to have that testing is available to everyone? No, we don't. And in fact, the test negative design is supposed to be beneficial in the case where you have different access to testing or to health services, so access to the hospital also. Because we're comparing two groups of people both with access. So the test positive and test negative both have access, so we're stratifying on this group. And so it is not a confounder like it can be in other types of observational studies. So that's often considered to be one of the sort of maybe a benefit of the test negative design is it conditions on this. So no, we don't need to have testing available to everyone.
Sorry, I guess it wasn't clear. Then the second question is about asymptomatic people, which I think is a similar argument. Oh,
for asymptomatic people, we need to not recruit them into the study. So that's my answer. No, the study design is to only recruit symptomatic people.
Great. I think we can continue, and then if there's more questions, we can take them later.
Okay, absolutely. All right. Thank you for the great questions. So it's also possible to directly estimate a marginal prospective risk ratio. And so this is the thing that we typically look at as potentially causal rather than the conditional parameter. So part of this work, I proved the identifiability of this parameter using a G formula. And then there's a natural IPTW procedure that can estimate it, and it's all very, very simple. In fact, the next part is really closely related to work done in the case control context, and so I should cite the work by Sherry Rose and Mark Vanderlaan, who looked at similar things for case control studies. So in order to show the identifiability of the marginal risk ratio under the test negative design, I'll define PC, which is the PDF of the covariate C under simple random sampling. And we also have a biased version of PC, which is the PDF of the induced PDF of the covariate C under the test negative design sampling. So this conditions on the inclusion criteria for the study. For simplicity, I also define S as just being having the inclusion criteria, the presence of the inclusion criteria for the test negative design. And Q naught is equal to the marginal probability of having the inclusion criteria for the study. And so the theorem states that under the test negative design sampling, the expectation, so it's like the biased expectation in a sense, okay, I don't like saying that, but anyway, the expectation under this biased sampling of pretty standard IPTW form where you have the outcome times an indicator of having a certain vaccination status divided by the propensity score times Q naught, so which is that constant there, the marginal probability of the inclusion criteria, is equal to the numerator or the denominator of the marginal risk ratio. Okay, so you do this once for each vaccination status, and then you can create contrasts. And so right away you can see that there's a natural IPTW estimator that we could potentially use here. And I want to point out that even if we don't know Q naught, we don't have to estimate it if we're taking ratios, so it'll cancel out. Okay. So, oh, and also want to point out identifiability here doesn't mean like causal identifiability. It means identifiability of a statistical estimate. Okay, just want to say that. So here is the proof. I think it's super interesting, so I wanted to go through it. So in the first step, I just write out what the expectation means. So we're starting with the numerator of the target parameter. So we're still in the simple random sampling. So just writing this out as a nested probability of the outcome conditional on vaccination and the covariates. And this is the PDF of C under simple random sampling. And then if you have the outcome, you automatically have, by the way we define the outcome, you automatically have the inclusion criteria for the study. So we can slip s equal to 1 into that probability. In the next step, we multiply the top and the bottom by the propensity score. So in the numerator, that pushes V into the probability. And then in the denominator, we have a propensity score also. In the next step, two things happen. I think this is where to, yeah. No, in the next step, we just multiply we use the definition of conditional probability to take the conditional probability of S out of this probability. And so these two things multiplying together gives you the joint probability. And here, this is where two things happen. So in the last part over here of the expression, we're going to apply Bayes' rule. And we're going to basically flip the order of the probability. So we're going to change this into these two things together. We're going to change it into the PDF of C conditional on the inclusion criteria. So that's the first part over here. So that turns into a product between the probability of the inclusion criteria and the biased PDF, the PDF conditioning on inclusion. And then on the other side over here, it's just to note that we can write the joint probability of Y and V as this conditional expectation over Y and the indicator that V is equal to whatever vaccine status. Okay, and then after this, we can move this probability out and we can move the summation out, or maybe the bottom's a little bit cut off. But basically that just gives us an expectation under the test negative design. So we have an expectation under the bias sampling, so conditioning on S is equal to 1 for C and also for Y. So this becomes identifiable up to this denominator. The propensity score in the denominator is not the bias propensity score that you can, obviously estimate in this design. Okay, so that's just the proof of the of that last thing. But now, to get the last piece of identifiability, we find that we can estimate that propensity score. So note that I didn't use the big test negative design assumption, so there must have been a problem, but here is where we use it. So if the vaccine has no impact on other infections, we have that the probability of the vaccine. So this is the bias propensity score, but just for the controls. So if we look at the probability of vaccination for the controls, using Bayes' theorem again, we can write this out. In the numerator, we have the probability of having the control condition multiplying by the prospective propensity score. In the denominator, we have the probability of the control condition. In the top, we have a condition on V, and the denominator is just by C. And so if we don't have if V is independent, if the probability of being in control is independent of V, these two things cancel out, and we just get a propensity score. So this means that if we use the control data to fit a logistic regression or whatever, and then make predictions for everyone in the study, we can get estimates of the propensity score. Then we can do a pretty natural IPTW. So it's great. It actually pretty much works out the way you'd expect, except that you need to use only the control data to fit your propensity score model. And so then you can either directly contrast the weighted proportions using this propensity score, or you can run a weighted logistic regression, which is more stable. But I just wrote this out. It's easy to understand. Okay, so pretty standard IPTW. Yeah. So all of that is estimating. All of that is talking about interpreting and then estimating the statistical estimand. Can we go any further in this context? So the causal interpretation of in the absence of interference would assume a stable Rubin's stable unit treatment value assumption. And so in particular, non-interference means that one patient's infection, illness, and hospitalization under their vaccination status could not depend on another patient's vaccination status, which is potentially problematic because we're talking about infectious diseases. But if we're going to assume that for now, we can define the potential outcome under vaccination status V as actually 3 potential outcomes. So it's a little bit more complicated. And consistency means that when we observe a certain vaccination status, we observe the counterfactuals. We have to be mindful of positivity, means that everyone was eligible for every vaccination level, conditional on their covariate values, C. And then we also have conditional exchangeability for the 3 outcomes, which is important to keep in mind because we need to unconfound all 3 of those outcomes. So under these, so these are the standard assumptions that you would make. And if we have those assumptions, then you can write the marginal risk ratio as a causal risk ratio and contrasting the probabilities of the potential outcomes being equal to the outcome of interest, COVID-19 hospitalization. And so similarly, we can write the conditional risk ratio in terms of counterfactuals, but since the risk ratio is collapsible, it's the same thing under no heterogeneity. But we probably have interference, or maybe it's important to consider interference in infectious disease context. So it's like an argument that's typically made, although I hear people arguing against it sometimes. So it can complicate at least the interpretation of the parameter that we're estimating. So interference here, well, it means that one person's vaccination status may impact another person's outcome, and here the outcome is infection and illness and hospitalization. And a lot of work has also sort of simplified the assumption to be that the community vaccination coverage is sufficient to describe the impact of another of the community on a member of the community. So basically I wanted to show how interference can impact the interpretation of the estimand, and so that's the simplification I made. But of course it could be much, and it is much more complicated than that. So following previous work that considers interactions between people in blocks, so assume that people only interact within blocks and they don't go outside their blocks. So we have blocks of individuals. We have a vector of vaccination statuses for each block, and then we also have vectors defined with the jth element removed. The assumption that we make for partial interference is that one person's potential outcome only depends on their vaccination status and the status of the rest of the block, excluding theirs, through a function of the other vaccination statuses. And so, for example, we can define that as vaccination coverage, which is just the proportion of people in the community the community around them that are vaccinated. And so if we make that assumption, we can define, these are standard definitions of causal effects under interference. We can define the direct, indirect, and total effects. The direct effect is if we vary vaccination status, but we hold block vaccination coverage constant. Indirect effect is the effect of changing the block coverage, and the total effect involves changing both. And also Umbert and Vanderweel pointed out that there are challenging identifiability assumptions for these parameters, which include no unmeasured confounders, not just of the individual, but of the block for treatment level and the individual outcome. And so we call these C and G. If we do make these assumptions so that we have measured all of these covariates, so even in like the best situation, if we're going to interpret, here I wrote down the conditional risk ratio. If we're going to interpret that conditional risk ratio, it turns into a ratio of probabilities, block-specific probabilities that are weighted proportionally to the size of the block. Okay, and so I wrote this out in terms of yeah, Emma?
Hi, Mireille. So we're kind of getting close to be out of time. So if we can wrap up in the next like 3-4 minutes, that would be great.
Thank you. So basically, it's really not a straightforward contrast, and in particular, these counterfactuals are in terms of the observed block vaccination coverage rather than something that's imposed. So not a straightforward contrast made in this setting if we're looking at our standard estimand of the conditional risk ratio. So I ran a simulation study. I'll go quickly through it. There were 3 scenarios. One was the basic setting. One included effect modification, and another one included partial interference with a specific structure. And that structure in the partial interference scenario was that the proportion vaccinated was an effect modifier of vaccination with the hypothesis that there was less exposure to the virus when more surrounding people are vaccinated. and that vaccination, in addition to lower viral exposure, is more protective than the sum of each individual element. And in all scenarios, we assume we set it up that there was no effect of the vaccine on non-SARS-CoV-2 infection or disease. We use the same DAG as shown previously, and so here are the results. This is for scenarios 1 and 2. The y-axis is risk ratio, and these are results for IPTW with controls. This is the light blue, and the darker blue is logistic regression. So in the standard scenario, and also we have the marginal risk ratio written here. So in the first scenario, which is the standard one, the marginal risk ratio is the same as conditional risk ratio, and everything does a good job because there's no effect modification. And as soon as there's effect modification, there's a little difference between conditional risk ratio and marginal, and logistic regression is overestimating vaccine effectiveness, whereas IPTW is right on, although you can see that it has a very large variance because it sees that there's a lot of effect heterogeneity and a lot of uncertainty about the average. For scenario 3, everything is off from interpretable parameters basically, so, or it's really hard to kind of interpret what these parameters are in this setting. So we calculate the conditional risk ratio under different proportions of the population being vaccinated, so 75%, 50%, 25%, and you can see there's like a large difference. And sorry, these are direct effects. So a large difference in these effects. The IPTW happens to estimate a marginal risk ratio that corresponds to the highest vaccine effectiveness under the highest vaccination coverage, whereas logistic regression actually estimates something that's even higher than all of those. So very uninterpretable. So I'll skip here. There's a lot of stuff that can be done here. Thank you very much to the seminar organizers for the invitation, and in particular, thank you to Denis Telbeau for collaborations and helping with the Q&A.
Great, thank you, Mireille. Yeah, so there is a question in the Q&A, but I think in the interest of time, let's switch to the discussion, and then hopefully we'll have some more time to discuss the discussion and the questions after that. So David, stage is yours.
Okay, thank you. Give me 1 second, I'll pull up my slides. I'm trying to be very fancy on Zoom today. So this is my new Zoom trick. So thanks, Mireille, for the great presentation. Thanks to the organizers for the opportunity to speak. I'm going to keep this pretty brief and pretty high level. I think you'll see that I'm a big fan of the work that Mireille has been doing and that others in the causal world have been doing to improve the test negative design and its relation to COVID and other diseases. So let me put myself in the center stage here. So this is my first big picture takeaway from Mireille's talk, is that there's no such thing as VE, and that context matters. And so to bring you to how I came to this realization, I'll tell you a little story about my involvement in sort of the COVID vaccine development process. So the year is 2020, all stories now begin in early 2020. And, COVID pandemic is spreading. And all of a sudden, biostatisticians are the cool kids on the block, right? Like, we're getting calls from the press. People want to hear from us. They want to know our opinions. My family actually cares for the very first time about what I do for work. And they're asking me questions about it. And we're all feeling very good about ourselves. And this was a new experience for me, at least, particularly speaking with the press. And so when I started, answering questions from reporters about COVID, the first thing I thought was, I'm going to be a statistician about it. I'm going to be a card-carrying statistician. I'm going to rain on everybody's parade. My role is to tell them how uncertain we are about everything, how not sure we can be. And that's sort of how I progressed. I wasn't going to be caught out on a limb, sort of pontificating, making predictions that might not come true. I was going to play the role of the good statistician. And that all changed, one day in December of 2020. And I remember I'm sitting at our breakfast counter. We have 2 young kids at home and working from home for about a year. So the house is a mess. Everything's in chaos. My kid, I think, is throwing yogurt all over the counter, and my phone starts buzzing. And I'm getting all these text messages like, wow, have you seen the results from Pfizer? Have you seen Pfizer's results? And I check my email, and I have like 3, emails from reporters asking for comments. And so I quickly Google like, what the hell is going on with Pfizer? And I see that they're reporting now 90% VE for their vaccine. And I was just floored. And I think this is the only time I let my statistician guard down. And my comment to the press was, right, like, wow, this is about as good of a result as we could hope for. And I realized probably what I should have been doing more there is providing context around that result. right? Because we fast forward a couple months and I'm getting more emails from reporters, I'm getting more questions from friends and family. They're saying, well, now we're seeing VE is only 60%, right? Well, why is that? Right, so you do your role of explaining the context. What does VE mean? What does VE mean in this context? Well, VE of 60% is actually not referring to preventing COVID. It's referring to preventing infections, right? And so people in the vaccine community sort of anticipated that vaccines would be better at preventing disease and infections, but that message never really made it across to the lay public. So we have this context that we really need to interpret VE. So fast forward a couple of months and now we're getting another VE of 50%, right? And that has to do maybe with the Delta wave or the Omicron wave. And so I'm getting questions now. So what's the context there, right? And the context in a pandemic is always shifting, right? It has to do with geography. Where are the cases occurring, right? How long has it been since people were vaccinated? There's all of these important contexts that we need to take into account to interpret something as simple as VE. So there is no such thing as VE. Context will always matter. But that's really perfect for people who like to think about causal inference, because causal inference is all about defining these different contexts, right? So we can think about probably the most basic causal inference example, saying identification of the average treatment effect. How do we do that? We look in very specific subgroups. We look at a very specific context and say, what's the treatment effect in that context? And causal inference teaches us how to weight that back up to a population level to define an overall context that we're interested in to hopefully answer relevant policy questions, right? And so that's really what I view as an enormous strength of Mireille's work, is it's starting to teach us how to do that in the context of COVID and in the context of a test negative design, right? First, she's providing us with the context of what is the outcome that we're even estimating. And in the context of COVID, so we've learned that's very important. 90% VE against symptomatic disease is not the same thing as against asymptomatic infection, or against any infection, or against severe disease, against medically attended disease, right? So even formalizing what is the outcome is a huge contribution of Mireille's work. Beyond that, she's also teaching us how to aggregate against different background levels of vaccination in the population, which of course is important context. As more people are vaccinated, background rates may diminish, right? Or they may not with the emergence of new variants. So Mireille's work in interference in this paper was really sort of eye-opening to understand how can we weight these specific contexts about what's happening in each block back to the population level and do that in an explicit way that advances policy goals. Finally, the last thing is Mireille's teaching us or providing us estimands and methods for estimating them that allow us to entertain the idea of effect modification, right? To pool risk across groups of individuals for whom vaccines work differently, which leads me to my next point, which is there is such thing as effect modification. And so this was, I think, the other really salient point I took from Mireille's work, is that if we're using logistic regression, right, in the context of a test negative design, and that method precludes accounting for effect modification, then that method shouldn't be used, because in the context of COVID-19 vaccines, effect modification is definitely present. We know that previous infection is going to impact the way your immune system works. It's going to impact the way you respond to vaccines. We know that age is an important predictor of whether these vaccines will work. And so ignoring this effect modification is not credible. And so really, I would say, I'll go on a limb and say very boldly that Mireille's method should probably be the standard for test negative designs. And that in the context of COVID-19, we absolutely have to account for effect modification. And she's providing us a very nice way to do that. Okay, so here's the last bit of food for thought, and then maybe I'll turn it over to questions for Mireille and an open discussion. So the test negative design, as Mireille alluded to, is an imperfect design, but it's a design that's not meant to be perfect. It's meant to give answers very quickly. And in the context of a pandemic, we've learned that that's really important. And so, one example of where the design potentially falls short, but could be improved, is the question of using a test negative design to disentangle waning vaccine efficacy and the issue of vaccine efficacy waning against the emergence of new variants. And so in the context of a test negative design, these are tricky issues, right? Because basically, if we expect that a vaccine's effect is waning, that means the longer out we look, we should see vaccine efficacy decreasing, right? But we could also be seeing a pattern of a new variant emerging on that same time scale. Right? And so how can we tell? Is it waning or is it a new variant? Right? And so that's something like a test negative design will sort of struggle with unless you design the study deliberately to answer that. But that kind of deliberate design basically requires waiting longer to get an answer. We have to wait a longer time. We have to wait well into the Omicron wave and see for people who were vaccinated more recently, did their efficacy wane during Omicron, right? So there's a trade-off here. We can improve designs like test negative design, right? But it comes at an expense of getting an answer fast. So I'm interested in hearing thoughts or opinions, or I'm interested to see where this field goes in ways that we can sort of adaptively respond with these designs, right? To get an answer quickly, but to refine that answer over time. Right? And so maybe there's ways forward where we can augment these designs where they can still give a rough answer quickly, but that can be refined and made better going forward. So here's my questions, open questions for discussion and specific questions for Mireille, if we're wanting for time. So how do we strike this balance, right? Between getting an answer quickly and answer, right? Versus getting the right answer, but taking more time to do so. And then a question for everyone, I guess, who works in this area, but for Mireille in particular, is thinking if we had to go to, the overlords of study design, our funders, and say we need a little bit more money to do one thing, right? And we wanted to do just this one thing to improve the test negative design. Maybe it's a design tweak, maybe it's getting some additional data, right? What should that be? Where should we prioritize our work in improving on these imperfect designs? And then for Mireille, I'm curious just to hear about her own lived experience as a statistician in this work, right? Where everything is moving quickly, everybody wants an answer yesterday, and we have to put on our statistician hats that say sort of like pump the brakes, let's be deliberate and think about this. So what has that process been like for you? Have you found that people are sort of open to new ways of thinking, or are they pretty sort of drilled into one idea of what a test negative design can offer? So thanks again to Mireille for a great talk. Thanks to everybody for sticking around. I look forward to a good discussion.
Thanks, David. So Mireille, if you would like to kind of answer to some of these questions or comments, and then we have another question in the Q&A.
Sure. Thank you so much, David, for the discussion. I really agree with your perspective, and that this is an imperfect design, and there are so many ways for bias to enter the estimation and problems with identifiability and stuff like that. So of course, like even beyond sort of like other types of observational studies. In my experience is pretty limited. I was on maternity leave for a lot of the pandemic, so like that was convenient for finding out how people are doing vaccine effectiveness studies in practice, except sort of retrospectively. I can read the papers. Some small experiences that people aren't really applying this design in its full sort of formality as what may have been happening a little bit more because of the changing with the influenza. Because of the changing conditions, people aren't going to get tests necessarily because they're symptomatic, and so right away they're sort of people saying, "I'm using test negative design," and then they're not. And so that's something that we have to be on the lookout for. There's already papers published with these kinds of non-test negative designs. I haven't tried to push. I haven't tried to really promote this method very much so far. I put it out there. It's I think now you're encouraging me to kind of insist upon it. But it's sort of a scary thing because these are huge data sets. People they just spend weeks and weeks running analyses, and so I think that the statistician hat is sort of a hard role, like wearing a statistician hat, or use a card carrying statistician. It's like a hard role to play when you're saying no, redo everything in this new method that should do a better job probably, and then explaining it, and what I mean. That's hard. And there's a lot of expediency, like we have to go fast. So there's a lot of pressure. We got to get these results out. Let's go. And then no, do an IPTW. It's hard for me, but I'm encouraged.
All right, thank you, Mireille. I think we have time maybe to take one more question from the audience. Actually, Eric Chekin has a question that he can ask himself. Eric, you should be allowed to talk.
All right, can you hear me?
Yes.
So thank you, Mireille. This was a really clear presentation, and David, your discussion was great, very entertaining, but also very insightful. So my question is, I'm just going to read what I had in the chat. So throughout Mireille's talk, it is assumed that healthcare-seeking behavior is constant, and that's kind of one of the things that people sell as a strength of the test negative design, that it tries to adjust for that, and you mentioned something along those lines. But of course, it doesn't do so perfectly because healthcare-seeking behavior is not deterministically related to whether or not you present and test. And as such, one may worry, and so in the test negative sample, there is variability in healthcare seeking behavior, and which is likely also predictive of vaccination. People with healthcare seeking behaviors are more or less prone to get vaccination. This will imply both residual confounding of vaccination and likely residual collider stratification bias due to healthcare seeking behavior. This will violate identification conditions. And so I just wanted to maybe hear your thoughts about ways of, if you could comment on this, on the impact of this problem on IPTW, and maybe ways of how to detect and possibly account for such bias. Thank you.
Thanks, Eric. That's a really great point. I read your paper, of course, where you comment on this and also talk about like care-seeking behaviors on a gradient rather than binary. And so I agree that this is certainly, in particular, would cause. I think I would be most worried about the confounding, the residual confounding that exists because of such a variable. I think I'd rather say that overall, this particular situation is very, very hard to unconfound these associations in any observational study. Like there's what you say, and there's a whole lot of like psychological and political perspectives also. All of these things are absolutely confounders because they affect you know, your interaction with the world and how likely you are to get infected. So a lot is a confounder. I don't know what else to say about it. Is this really challenging? And I think what I see in practice is there's sort of a limited number of confounders. People kind of focus more on comorbidities as confounders rather than sort of, there's risk aversion, there's perspectives on the pandemic. There are scores that could be constructed to sort of, you know, measure on with some dimensionality people's willingness to adhere to, let's say, government recommendations, and also their interactions with the world, how much risk they take, or even if they perceive going out in the world as being a risk taker.
Thank you for that. I think that makes a lot of sense. There are some, and I may not actually be one of those people, but there's some who actually advocate completely abandoning the test negative design. And I was actually listening this past week. Mark Lipsitch was on the New England Journal of Medicine, had him being interviewed about the role of his new forecasting gig at the CDC. And one of the comments he made that I actually resonated with me was that the US needs to implement basically a surveillance system that takes random samples of a population and in sort of a cohort fashion, just for the purpose of monitoring vaccine efficacy, effectiveness. And he made a point that, in fact, the UK has such a system. Many other countries, Israel obviously has it's a little easier because of the centralized healthcare system. It's more than a random sample, it's the whole population essentially. And so maybe at the risk of being a little provocative and maybe countering David's promotion of TND, what do you think of that? I mean, I think maybe ideally having both would be best, but would that maybe sort of start addressing at least some of the selection bias concerns, if at all?
I completely agree. I think those are much more reliable study designs. Maybe David wants to. Yeah.
So it's weird that I've found myself defending test negative. We're trying to salvage it, I suppose, because I spent about a year at CDC telling them that like probably they should reconsider flu test negative designs as a way of monitoring vaccine efficacy, because there are so many flaws that maybe in some situations, you know, we might have to just dispense with it and really revisit the way we do vaccine effectiveness monitoring. I didn't find much of an appetite for that amongst the collaborators I had at CDC, but if people like Mark Lipsitch are now, you know, screaming this from the mountaintops, that may be enough to move the needle. And I for one would certainly be very happy about that.
Great. So I think we should wrap up. Sorry to interrupt this, such a nice discussion. But yeah, thank you all for attending and asking questions. So 1 second. All right, great. Right, so once again, thank you to Mireille and David and Denny for answering questions, and thank you to Eric for actually such a nice addition to the discussion. Next week, we actually have no seminar due to the ACIC conference, or I guess ACI conference. And then in 2 weeks, we will have a talk by Bin Yu from UC Berkeley on predictability, stability, and causality with a case study to find genetic drivers of a heart disease. So we hope to see you all there. If you're going to ACIC, hope you enjoy it. Thanks again to today's speakers for very nice talks and discussions. And yes, we'll see you in 2 weeks.